There we go. We have Dr. Guido España. Guido is a research assistant professor in the Department of Biological Sciences at the University of Notre Dame. Guido's research is focused on supporting decision-making with the use of mathematical and computational models to understand the dynamics of infectious diseases. In particular, his interests include the use of agent-based models to evaluate the impact of public health interventions. His research has focused on the COVID-19 pandemic and on the evaluation of vaccine impact and vector control in vector-borne diseases, such as dengue, chikungunya, and Zika. And Guido, I will just give you a little heads up when you have about 2 minutes left in the chat.
Okay, thanks.
Yep.
Does this look okay?
Looks great.
Okay, cool. Thank you. Well, what I'm going to talk about is basically my experience in the last couple of years using agent-based models to support decision-making in during the pandemic in the city of Bogota, Colombia, which is where I'm from. So just basic description of what an agent-based model is. It's any model is just a computation, an abstraction of reality. And then particularly in agent-based models, what we do is to simulate different interactions among individuals or agents, which can be people or animals or other type of agents. This methodology is used to represent complex systems, and it's often used when you need to represent heterogeneity or emergent patterns. I'm just going to focus quickly on the experience with the agent-based model that I've been using for COVID-19. Just in case anyone is interested in how can you do agent-based models, there are many software available, many different types of software, such as NetLogo, AnyLogic, or a little bit more intense like C or C++ or Python, Java, and other programming languages. Now, this is a work that I've been doing for the last couple of years with a lot of collaborators back home in Colombia. And the idea is that early in 2021, the situation in Bogota was that there had been 2 waves of COVID-19, and the schools were closed for almost a year, which was causing a lot of social issues in the city, increasing the risk of poverty for some populations, for instance. And what we were trying to do was to develop some simulations, scenarios to test different strategies to reopen schools at that point and see what the impact of these strategies would be, trying to help decisions that were being made in the Secretary of Health or the Secretary of Education in the city. So just a little bit of background. At that point, around 30% of the population was estimated to be infected in November 2020 in Bogota. Now, I think it's around 80% or more. So things have changed significantly. Bogota is a very dense city with more than 8 million people living there. And again, at that point, there were more than 600,000 confirmed cases, but that has significantly increased. We use a model that was actually developed by the University of Pittsburgh. It's called FRED. It's a framework for reconstructing epidemic dynamics. It's a very flexible and adaptable model that has been used for different diseases. And we modified it and used it for our own needs. And what we did was to represent every person in the population as an agent. And then what I'm showing just here is that these agents have different activities. So they can go to work, they can go to school, they can just hang out in their communities, or they can be in a college campus or in long-term facilities, long-term care. So in these daily activities, the agents can find infectious agents, and this can find susceptible agents. And if they interact with each other, they can transmit the virus. and they can take it home, take it to school, to the communities, and that's how we represent the epidemic in the city. Now, for an agent-based model, it's important to have what's called a synthetic population. A synthetic population is basically a representation of the characteristics of the population that you want to represent in your model. So we were very interested in the demographic characteristics of the city, geographic location of houses, the workplaces, where are they located, the sizes of these workplaces, the composition of the houses, and of course, where the schools were located as well. So we got a lot of information from different places, some open access data and some data specifically from the city. And then we built our synthetic population of Bogota. Using this synthetic population, what we did was simulate the transmission of the SARS-CoV-2. But because there were a lot of interventions at the time, for instance, reducing mobility in the city, there were long confinement periods, and specifically this two, I don't know if you can see my mouse, but around April and then in July, there were some prolonged lockdown periods that of course affected the dynamics of transmission in the city. So what we did is that we took data from Google Trends, from Google Mobility, was releasing some, I think it still does, some data on how mobility has changed during this period in the pandemic compared to some date before the pandemic. And so these are the trends that we can see how the mobility has been was reduced in these periods, and then it increased significantly. And this is 2001 right here. Now we also use data from the Grant Data Project that has geographic specific data. And you can see here a little bit, the dark colors show how much an increased mobility, whereas the lighted colors show that there is a decreased mobility. And you can see that there's always some concentration of dark colors in these areas that tend to be a little bit poorer areas compared to the ones around here. So there is some heterogeneity in how people respond to these interventions. Not everyone stays at home at the same level because some people may not have the resources required for that. So we included this in the model, and then what we did was that we used some calibration methods to reproduce the daily number of deaths in the city. This is again up to January 2021, where we only had 2 waves of the epidemic. Interestingly enough, the model actually reproduced some data that was not included in the calibration, which is the attack rate, which is the proportion of people that has already been infected at the point, and which is around 30% by then. We could also use this model to evaluate the proportion of people infected at that point in different areas of the city. And because there was a higher mobility in this type of areas that, as I just presented, there's also I'm sorry about the dog. There's also an increased infections attack rate in these areas. Okay, so we had a few scenarios of school reopening. These were thought, again, to inform decisions that were being made at the point. So what we did is that we reduced school capacity from 35% to 100% starting in January 25th, 2021. I'm going to have to take the dog out. Okay, sorry about that. And we had an assumption that children were less susceptible to infection than adults, and that there was an adherence of face masks within schools of 75%. We also had a strategy of reopening based on age, and in which we had different grades that would open at different capacity levels. And okay, so with this, what we tried first was extreme scenarios. So extreme scenarios is all schools remain closed or all schools open at full capacity. And what we can see is that when school remain closed, that is the red line here, at the point, and assuming there were no other variants circulating in the city, we saw a decline in cases. Again, this is with the assumptions that we had at the moment in the model. We also saw something very interesting, which is that if there had not been any interventions at the point, this was the dynamics of the epidemic in the city, which is much sharp and higher than what we observed in the data. And then finally, when we reopen at full capacity, we see another outbreak occurring in middle April in the city. Now, this is at full capacity. So the idea is how we can manage this, how can we manage this wave so that it is not as high as it looks there. First, we saw what would be the impact of delaying school reopening so that it wouldn't be right at this point in the middle of January, but it would be in February, March, or April. And what we saw was a difference, a very small difference in the effect of delaying the reopening in terms of the magnitude, but it would cause at least that the peak would not be as high because it's not overlapping with the current wave there. Now, when we reduce capacity of all schools to 35%, we saw there was a very small difference in the impact of having schools open at this capacity of having them closed. When we look at different grades, so bear with me, this is a lot of colors. What the important color here, it's the red one, which is what happens if we only reopen pre-K grades. And what we see is that reopening even at full capacity did not produce a new wave. And that's true for any capacity level, but we also saw that primary schools did not have a large impact either. When we reopened secondary schools, which is the green one, then we notice a higher impact. So we can see primary and then secondary schools. Now at lower capacities, we can see, for instance, at 50%, the impact was very small compared to the previous two outbreaks of having all schools open at 50% capacity. When we just look at the total numbers for each of these scenarios, we basically just see the same thing, that pre-K grades have a very small impact in the overall dynamics in the city compared to, for instance, reopening secondary grades at this point. Now, I think I'm almost done with my time, but what the message I wanted to get across here is that was at the point, and that was useful at the point to inform what we wanted to inform in terms of decision making, but the pandemic has continued to evolve and there is different variants. So we had to deal with other variants like alpha, gamma, mu, which actually gamma and mu caused a third wave in between May and July in the city. That was the largest that we had seen at the point. So we had to continuously update this model to include new variants or different factors that affect the dynamics of COVID-19 in the city and continue to be able to inform decision makers. Now, what are we working right now? It's we were first trying to look into what would the impact be of Delta, which is you cannot really see it much in the deaths, which is this this frame here. The red dots show the data. Basically, it's gone down. This was by October. We had different scenarios. One pessimistic, that was the black one. And we didn't see actually any increase due to Delta in the city in deaths. And we can see this here in the reproduction number. When we see the data again is the red, very noisy line. what we're starting to see was that, okay, the model is fitting fine for the reproduction number of delta. There's not an increase of deaths, and the ICU demand, which is this one here, all looks fine with the data. But then suddenly we see Omicron in the city, which is this very sharp increase in the reproduction number. This is late December 2021. So this is what we're working on right now, trying to look at different scenarios of Omicron in the city and what the impact would be in different aspects. So just in conclusion, we use an agent-based model of COVID-19 to inform decision makers in Bogota, in Colombia. We found at the moment of this study that younger children or pre-K students had a lower contribution to the overall transmission dynamics of the city, even at full capacity. And this is due to contact patterns. This is due to this smaller population compared to the other ones. And well, updating the model continuously is important to continue to provide relevant projections to decision makers. And
all right. Thank you so much, Guido. That was
sorry about the dog.
That's okay. Jasmine says hello to Milky Way and Loki. We are a pro dog presentation group. We are going to move on, and you guys can feel free to ask everyone questions at the end when we're done with all the presentations. So now we're going to go to Caroline Mburu. Caroline is a PhD student at the Kenya Medical Research Institute in Kilifi, Kenya, and registered with the London School of Hygiene and Tropical Medicine. Her PhD thesis focuses on the calibration of statistical and mathematical models to serological data to estimate antibody response to vaccination, assess the impact of vaccination programs, and predict the need for supplementary immunization activities in Kenya. So she actually has a recording that we are all going to watch. So do not try to jump in with questions because that won't work. So Caroline, if you want to go ahead and get that started for us.
Hi, I'm sharing the screen. I'm sorry, my internet is a bit unstable, but hopefully it plays to the end. Good afternoon. My name is Caroline Mburu, and I'm a second year PhD student at the London School of Hygiene and Tropical Medicine. I'm based at Cambridge Wellcome Trust in Kilifi, Kenya, under the initiative to develop African research leaders. So today I'll talk a bit about my PhD work, which is on applying mathematical modeling to serology data in order to assess the impact of vaccination programs in Kenya. So I'll start by introducing the topic, maybe introduce vaccine preventable diseases and say something about serology and modeling. And then I'll go and talk about my first objective in detail. So for this, I've sort of finished and I have the results for it. So I'll talk about application of a static cohort model to estimate changes in measles immunity. And then for my other two objectives, it's more of a work in progress, but I'll briefly just mention about them. So application of a catalytic model to estimate the force of infection for hepatitis B, and the application of dynamic transmission model to estimate the age-specific magnitude of future outbreaks for measles and rubella in Kenya. So what I have here are two figures, and one is showing the deaths caused by vaccine preventable diseases in 2010. And then the next one, the one on my right, is showing deaths caused by vaccine preventable diseases in 2017. I've highlighted the diseases of interest, at least in my work. I will not be dealing with tuberculosis. So what we see is a substantial decline in vaccine preventable diseases between these two time periods. So this change was brought about by several factors, the main one being introduction of new vaccines. So between the two time periods, 113 countries introduced new vaccines and more than 20 million children were vaccinated. Now, despite the gains that we are seeing on a global level, countries in the low and middle income countries continue to lag behind in the progress towards the elimination of these vaccine preventable diseases. So one of the main reasons for this is gaps in population immunity, and this is brought about by suboptimal performance of the immunization programs. Now, vaccine preventable diseases are prevented through vaccination. And according to WHO, 3 million deaths are averted annually, and 1.5 million deaths stand to be avoided if vaccination coverage is improved. Now, to assess vaccination coverage, we normally use the third dose of diphtheria, tetanus, pertussis received by 12 months. So what they use is mostly the administrative method. So this involves counting the number of doses that have been given. You divide by the target population. So the other method that they use is household surveys. So you conduct surveys in households where that have the children in the age group of interest, and then you collect the vaccination status by checking the immunization cards or caregiver record of the history of vaccination. So the main disadvantages with this method include most times you find there are inaccurate records of the number of doses that are given, there are invalid assumptions about the size of target population, and more often than not, there will be incomplete vaccine information. So most importantly, and I think the main disadvantage of these methods of estimating vaccination coverage is that vaccination is not equal to immunization. So both methods do not really give any insight into population immunity. So this is where serology comes in. So serology or seroepidemiology is the use of data on the prevalence of biomarkers of infection and vaccination in order to understand the epidemiology of infection. So ideally, serology surveys involve you collect serum samples from the participants, and then you take the samples to the lab and check for the presence of antibodies of diseases of interest. So for instance, if you're interested in measles, you check whether they have antibodies, measles antibodies, and then so each of it's more, you find different diseases have different cutoff thresholds. So depending on whether the antibodies are above or below a cutoff threshold, then you'll be able to tell whether that participant is immune or not. So in a way, when we use serology data, then we are able to, and especially if you have now demographic information such that you can be able to tell the age of the participants, then you're able to provide age-specific immunity profiles. And these are important because they guide targeted vaccination, because so you're able to tell which age groups are more susceptible than the rest, or which age group need booster doses, and which ones are immune. So the other thing is, if you combine the age-specific serology data with mathematical modeling, you are able to predict disease resurgence. And again, this is disease resurgence in specific age groups. So in a nutshell, serology data provides a better way and a more accurate way of evaluating the performance and the impact of vaccination programs. So this brings me to my first objective, so which was on evaluating the utility of a supplementary immunization activity to mitigate the risk of measles outbreak in the post-pandemic period. So from here on, this is more of a measles campaign when I talk of a measles supplementary immunization activity. So the aims of this objective specifically were to predict the changes in measles immunity during the pandemic. So we had data on we had serology data of 2019, that's for measles, local contact patterns and vaccination coverage estimates. So we used this to predict changes in measles immunity over time, given different values of vaccination coverage. And then we're also interested in estimating the probability of a large outbreak before and after the COVID-19 restrictions are lifted. And finally, we were interested in assessing the impact of a measles campaign on this outbreak risk. So a bit background on why this objective was important. So this was brought about by, we had the COVID-19 pandemic in 2020, and one of the indirect health impacts of the pandemic has been a disruption of vaccination services. So the map that I have here, it was from a pulse poll that was conducted by WHO, and we're looking at the level of disruption of vaccination services in early 2020, immediately after the pandemic. So what they found for Kenya was a marked reduction of about 50 to 80%. Now, this disruption in vaccination services was bound to have an effect on the vaccine preventable diseases, and in particular measles. So for measles, we have a first dose that is given at 10 months, and we have a second dose that is given at 18 months. So in addition, we also have the measles SIAs. They happen every 3 to 4 years, and the importance is to improve the immunity of the population. So we had a planned SIA in February 2020, but following the pandemic and guidelines from WHO, this was postponed. And so with this in mind, we hypothesized that there would definitely be a risk of measles outbreak, and wanted to predict the magnitude of this outbreak. So in modeling this, we employed a static cohort model of measles immunity. So this was adopted from work that had been earlier done by Sebastian Funk in 2019, modeling measles in 17 countries in Europe. So what we did was, this is the data, the observed data that we had. We knew what the proportion of the population was immune in the country in September 2019, and we wanted to find out, given the changes in the vaccination coverage over time, so what proportion of the population would be immune in December 2021. So that was our study period. Now for measles, there are several factors that drive measles immunity. So the first one is birth rate, and then there's the vaccination coverage, that is the uptake to which infants when they're 9 months are being vaccinated, and at 18 months for the second dose. There's also the vaccine efficacy. Now usually waning immunity from natural exposure and demographic changes also affect measles immunity over time. So however, given the short time period of our study from September 2019 to December 2021, we assumed that the effect from these three would be negligible. And so in our model, the main drivers of immunity was vaccination coverage and vaccine efficacy. And we also assumed a constant birth rate. Now, so I'll just present some few results. The first one is a graph that's showing the predicted age-adjusted immunity. So in Kenya, we had our first case of COVID-19 in March 2020. And then in April 2020, the government imposed some movement restriction measures. Now, after March 2020, we were not really certain of the actual reduction in vaccination coverage. And so we had 4 assumptions of the reduction in vaccination coverage. So that's 0, 15, 50, and 100. So on the x-axis, I have the dates, the time period in dates. I have in months and years. And on the y-axis, I have the proportion that is immune, so the prediction from the model. Now, the first thing to note is that there was a decline in the predicted immunity over time, and this decline was was proportional to the assumed reduction in vaccination coverage. Then there's also the other thing of the herd immunity threshold. So using a measles reproduction number of 18, we calculated a herd immunity threshold of 93%. And so when you compare the predicted immunity with the herd immunity threshold, we find that in February 2020, so this is when we were expecting to have the measles campaign, our immunity was falling just below the herd immunity threshold, which showing that we were at a risk of measles outbreaks. And so this SIA or this campaign would have been very well timed if had it happened at that time. However, after the movement restriction measures, so the movement would, we assumed a reduction in the basic reproduction number by 50%. So when you calculated the resulting herd immunity threshold, that was 86. And so when you compared the predicted immunity with the new herd immunity threshold, this sort of mitigated the risk of measles outbreaks. So again, for the predicted outbreak risk, we did the same. So these were the vaccination coverage scenario. So to calculate the probability of a measles outbreak, we used both the herd immunity threshold and the predicted immunity at each of these time points. So the one in red is showing the outbreak probability assuming normal measles transmissibility. That is no movement restriction measures, or the green one shows the the predicted probability outbreak probability assuming a 50% reduction in transmission as a result of the reduction in the movement. As a result of the movement restriction measures. And so again, we find that the predicted outbreak risk was much higher, but this was somehow mitigated due to the movement restriction measures. So again, we simulated the impact of an SIA. So we took 3 arbitrary points in our time period, and we wanted to see what would be the impact of an SIA. So we reduced the population that was susceptible at each of these time points by the effective coverage of the SIA. That's the vaccine efficacy and the vaccine coverage. So we reduced the population that was susceptible using the effective coverage of the SIA. So we simulated an SIA in under 5-year-olds, under 15-year-olds, and this is in a situation where there's no SIA. So again, you see the outbreak probability if you compare, for instance, in December 2021, assuming, let's say, a 50% reduction in vaccination coverage. So the under 5, the risk goes to 0, under 15, the risk goes to 0. So these are the upper limits. While the in a scenario where there's no SIA, the risk is about 50%. And so the main idea here was, or the summary was, that an SIA that was scheduled for February would have been very well timed. The risk of a large measles outbreaks was partially mitigated because of the movement restriction measures, but we predicted that once the measures were lifted, then we would expect to see measles outbreaks in the country. So that actually happened because the movement restriction measures were eased towards the end of 2020. I mean, in the beginning of 2021 and end of 2020, and we saw, measles outbreaks were reported in the country. So following that, in July 2021, a campaign was conducted in under 5s. A high coverage campaign was conducted in under 5, which has been successful so far in controlling the measles outbreaks in the country. So for this should be the second objective. This is to assess the impact of a hepatitis B vaccine on hepatitis transmission in Kenya. And so some of the main objectives, some of the specific objectives in this main objective is to look at, to estimate what is the prevalence of hepatitis B in Kenya. So for that, we're going to use the serology data, and it's going to be more a descriptive, statistics. But also we want to fit to estimate the potential changes in the course of infection over time. So that will give us an idea of, so has there been, if we found the force of infection is reducing over time, to give us an idea of the impact of the vaccination program over time. So the other question we want to look at is, we currently have 3 doses of hepatitis B vaccine in our immunization program, while the recommended doses is 4, and so we want to see whether there's a case for introducing the vaccine based on the current levels of, what proportion is immune, what's the prevalence, and what are the changes in the course of infection over time. So for this, we'll employ a catalytic model. So the main assumption here is a constant course of infection. So you just have your susceptibles, and you can stratify them based on age, where you have a catalytic model that is age dependent, maybe in different age categories, or you can just have a catalytic model that is age independent. So for this analysis, we are hoping to sort of utilize the two and compare the results. So we'll fit using Markov chain Monte Carlo methods in assuming a binomial likelihood. And for the third objective, sorry, it's not objective 4. Here the aim is to develop a dynamically structured model. So measles and rubella have the same mode of transmission, and so we hope to fit same models, of course, with varying parameters for measles and rubella to predict what is the age-specific magnitude of future outbreaks. Then also, given the different vaccination schedule that we have for the two diseases, we want to try out different combinations of the first dose, the second dose, and the SIAs, and conduct a cost-effectiveness analysis just to see which of these combination of vaccination schedule is the most optimal one for the effective control of both measles and rubella. So for this, we'll extend an SIR model. So for this has a maternal immune compartment to also fit vaccination compartments, which may the model or the structure may of course change or not change, depending on more information as they go ahead with the work. So thank you so much for your audience. I welcome any questions. And before I go, I'd just like to thank my supervisors and everybody who's been involved in generating the data and assisting with the analysis. Thank you.
Thank you so much, Caroline. That was great.
Thank you.
All right, so now we are going to have Dr. Tufail Malik, who was one of your judges, so you know who he is. If you want to go ahead and get started.
Sure, thank you. Just let me share my screen and put it in the full screen mode. Okay, hope you can see my screen better.
Yep, looks great.
All right, excellent. So, first of all, great job, everybody, on those presentations. It was wonderful. So I will try to stick with the idea of giving you students, the talk in the sense of showing the applications of mathematical models in infectious diseases. And I will use one of the models that I have built and I'm analyzing here at Merck. So mathematical modeling, we here at Merck in particular, and elsewhere in general, the models are supposed, to inform policy making, right? And they try to answer these questions as you see on the screen. So we use those models. There are dynamic transmission models where we use the differential equations and so forth. And then there are static models or Markov models. And they're used to assess, epidemiologic impacts of interventions in infectious diseases, such as the number of disease cases avoided, the disease deaths averted, the herd effects from vaccination of one group on another, the number needed to vaccinate, or on the flip side, you can, assess the number of cases saved per vaccination, and the quality adjusted life years gained or lost. And then we also, use those models to answer some economic related questions, health economic questions. So the economic impact of an intervention, for example, vaccination, the cost of the disease, the cost of vaccination, and using, some of these parameters, then we come up with the so-called ICER, or incremental cost effectiveness ratio, that tells whether a certain intervention is beneficial or not. So as an example, to demonstrate this, I will show you how I'm using a model for pneumococcal disease. The pneumococcal disease is caused by a bacterium called Streptococcus pneumoniae. And there are more or less 90 serotypes of this bacterium. And the primary carriers of this bacteria is little children, basically. So almost all infants, they carry this bacterium in their nasopharynx. But sometimes it may cause infection, it may cause pneumonia, it may cause blood infection, which is called bacteremia. I think I have a slide on the in a second. Or it may cause meningitis, which is the infection of the inner membrane of the brain, or the inner ear infection called otitis media. And it is spread by, from person to person through respiratory secretions. And the older adults are also susceptible to this disease. So here are some of the manifestations that I described earlier. So mainly it starts with the nasopharyngeal colonization of the bacteria. It may cause ear infection. It may cause blood infection. It may cause meningitis. So there are vaccines which are age-specific and serotype-specific, so they target particular serotypes. And there are different vaccination programs according to the age groups, basically. In US, we have the so-called PCV13. It's a 13-valent vaccine that targets 13 serotypes, and that is implemented in the US in children. Then there are adult vaccines. So just recently, last October, 2 new vaccines came out in the market, PCV15, which is Merck vaccine, and PCV20. And then there is another adult vaccine that's called the polysaccharide vaccine, that's PPSV23, so it targets 23 serotypes. And then there are a number of more serotypes in the making. So pneumococcal disease, as soon as the PCVs, or the so-called conjugate vaccines, came into the market, starting with PCV7, which was the 7-valent vaccine that was introduced in 2000 in the US. As you can see, there was a sharp decline in the IPD, or the invasive pneumococcal disease incidence in children under 5 years of age. And similarly, later in 2010, that was replaced with a 13-valent vaccine. And as you can see, that had another impact on the IPD. But when it comes to the adults, the impact is not as prominent as in the children. So the key questions from the model revolve around the epidemiologic and economic impacts of the vaccination strategies. So as I described earlier, we want to know, we want to assess the decline in the prevalence of circulating serotypes. So now I'm, specifically talking about pneumococcal disease. So the decline in the prevalence of those serotypes and the reduction in the resulting pneumococcal disease, and likewise the deaths that are associated with some of those manifestations, and the changes in resource use and the treatment costs. And the fundamental question that we try to address here is how cost-effective is the inclusion of a pneumococcal vaccine as a routine vaccination against pneumococcal disease in the United States compared to another pneumococcal vaccine. So mathematical models are very effective tools in answering these kinds of questions. And there have been many dynamic transmission models in this area. So I want to mention, most of the dynamic transmission models, they do not really incorporate the carriage part separately. So we have to think of these two things. One is nasopharyngeal carriage, and that is what gets transmitted, right? And then that can develop into an infection, into a disease. So there are two different things going on in here, right? So, but most of the dynamic transmission models, they deal with they have the pneumococcal disease as the endpoint, and not the carriage as such. One of the major reasons is that the data on colonization is very, very scarce. So we do not really have much data on the carriage part of this disease. So I'm not going to go through all these detailed, description of the model, just to give you an idea of how the model is laid out. So this is the flowchart of the unvaccinated compartments. And then here are the vaccinated compartments. Again, it's just to give you an overall view, and I will give you a very high level description of the model in a moment. And as you know, we mathematicians, we just take those flowcharts and turn them into abracadabra, turn them into differential equations, right? So this is a system of differential equations. There are many of them, 30 to begin with, but depending on how many serotypes you want to consider and how many age groups you want to consider in the model. For example, for the US case, I have 9 serotypes, or serogroups, I should say, in the model, and 6 age groups, and I'm looking at 2,300 plus differential equations. So here is the very high level description of the model. So we have the population divided into compartments. So it's a compartmental model, just like the SIR models you guys just presented. So we divide the population based on their carriage and disease status and based on their vaccination status. So here we have the non-colonized individuals who can acquire colonization and become colonized, and they can clear the colonization. But right at the time of colonization, they can also develop a pneumococcal disease. And those with the disease, they can recover. So this is the overall, 3 major compartments, so to say. And then there is vaccination, right? So this vaccination represents the cohort vaccination of the children, of the infants. And then there's a continuous vaccination also. And the individuals who are colonized, most of the time, it is asymptomatic, and so they can also get vaccinated. So this is the overall, flow chart of the model. And the very, so here are some properties of the model. So as I said, it's a compartmental model based on a system of ordinary differential equations. It is stratified by age, and it involves carriage transmission, and it incorporates serotype-specific and age-specific vaccination. So in the model, you can have a separate vaccine for pediatric age groups and a separate vaccine for the adult age groups, as is the case in the US. And we are also incorporating co-colonization, meaning colonization with 2 different serotypes. There is evidence of as many as up to 6 serotypes, colonization at the same time. But the probability of carriage or colonization with 2 serotypes is significant, and therefore we are only assuming co-colonization with 2 serotypes. And then we incorporate, as I showed you, the pneumococcal disease separately from colonization. And the beauty of the dynamic transmission models is that they can consider herd protection built into the model. And then we have the serotype replacement phenomenon in the model, followed by following the vaccination. So if you're and it's basically in terms of a parameter called the competition parameter. So if you're currently colonized with a certain serotype, then what's the likelihood of acquisition of another serotype on top of that? And the model, like I said, it is flexible in terms of how many serotypes you want to consider, or how many serogroups you want to consider in the model, how many age groups you want to consider, and what vaccination scenarios you want to assess. You can, like I said, you can implement a separate pediatric vaccination and a vaccine or a combination of vaccines in the adult population. And what disease manifestations, like I showed you earlier, meningitis, bacteremia, and so forth, which ones of them you are interested in. And the assessment of herd protection of vaccination of one age group onto another age group. So that leads to how many differential equations you will get and what inputs are relevant. So to give you, I'm cognizant of time also. So this is the overall, inputs that we that go into the model. It's a data hungry kind of model. So you want the demographic parameters, including the mixing patterns, because whenever you talk about the transmissible disease, the mixing patterns matter. The disease-related compartments, the carriage-related compartments, and what else? The vaccine-related compartments, right? Or inputs, I'm sorry, the vaccine-related inputs. And when doing the cost or economic assessment, we need the costs and utilities. And so just to give you an idea of what kind of data goes in. So as the initial step, we want to be able to say that our model can predict the disease properly, and that includes the model calibration. So in the US, the vaccine recommendations have gone through many changes over the years, and they have been very, very complicated, complex. Recently in October, the ACIP has tried to simplify those recommendations. So we want to take the data. So this is the IPD, or the invasive pneumococcal disease data obtained from the ABC's data source from the CDC. And we are trying to then fit our model through the data, right? So you have learned in your numerical methods courses, different ways to fit the model through the data. And we are applying one of those techniques called the least squares approximation, okay? So some of the parameters are available in the literature, but to get some other parameters, we then fitted the model to the historic data, as I showed you. But then here's the fun part, that is that we have the IPD incidence data stratified by age and by serotype. So here we are talking about 6 different age groups and 9 different serogroups, right? So what we tried to do is, I will skip through these quickly. So first, we made sure that the model produces a steady state solution in the pre-PCV time period, right? Before the PCVs were introduced, before the vaccine is introduced, we are assuming that the population is at a steady state level. So here is the snapshot in the year 2000 of the population in each of the serogroups, each of the 9 serogroups, as you can see here. And each of these 2 panels is the age groups, right? 0 to 2 age group, 2 to 4 age group, and so forth. So in the orange is the data, and the blue here represents the model. So as you can see, we have some good, fitting of the model outcomes for the IPD incidence in each of the age groups and for each of the serogroups here. So that then led to the PCV era, right? Now you introduce PCV 7 in the year 2000, and this is basically the data fitting for each of those age groups and for each of the serogroups. So here we are seeing the PCV 7 serotypes, okay? So let me tell you, for example, this is the 65 years age group, the data and the model. that represents the IPD incidence, total number of cases. And this is for PCV7 serotypes only. Okay, so this is the data, this is the model. So as you can see, this is fitted pretty decently so that we will have confidence in the model projections. So here is the PCV13 additional serotypes on top of those, in addition to those PCV7 serotypes, excluding one of the serotypes. I will not go into that detail either. So here you can see the PCV7 serotypes went down after 2000, but those additional serotypes basically went up until the introduction of PCV13 here in 2010. So on the left again is the data, on the right is the model for each of those serogroups. So just to show you, the first step of a dynamic transmission model to fit with the data. So here is the overall fitting for each of the age groups where the serogroups are all aggregated. So in other words, all serogroups 65 plus is right here. This is the data and this is the model fitting. So, putting all of that together, then of course will give us a good overall IPD incidence fit. So this is the overall model fitted to the overall IPD incidence data. So now that we have a well-fitted, model, this can now be used to basically answer all the questions that we asked earlier. We can assess the carriage prevalence in the future with a particular vaccine. We can assess the disease cases, the breakthrough cases, the disease deaths, the number needed to vaccinate, the qualities lost or gained, and we can assess the cost effectiveness of any new vaccination strategy. So I just wanted to give you a kind of demonstration of how to use a mathematical model for this purpose. So that's all. Thank you so much. If you have any questions, I'll be happy to take those.
All right, thank you so much. That was wonderful, as always. We're going to go on to our last presentation and then do a round of questions for everybody at the end. So our next and final presentation is going to be by Dr. Darcy Rao. Dr. Darcy Rao is an acting assistant professor at the University of Washington. She is an infectious disease epidemiologist with training and experience in mathematical modeling of sexually transmitted infections and cervical cancer. Her research interests center on using mathematical models to bridge epidemiologic research and public health practice, with the goal of informing the design and implementation of effective programs and policies. Her current projects include clinical research to evaluate alternative cervical cancer screening strategies for women living with HIV in Washington state, mathematical modeling of HIV and HPV co-infection dynamics to inform cervical cancer prevention in low and middle income countries, cost-effectiveness analysis of cervical cancer prevention strategies, and agent-based modeling to evaluate changes to STI screening guidelines in the US. So she does quite a lot of things. I'm very excited to hear her research.
Thank you for that introduction. And I didn't realize you were going to be reading that out loud. So I'm sorry I gave you a mouthful to present there. Well, I'm going to just share my screen here. And thank you so much for this opportunity. I'm really excited to be here, and I'm really sorry that I wasn't able to see your presentations earlier. But I hope you all enjoyed coming up with your projects. Okay, so before I get into kind of telling you about the project I was going to present today, I just wanted to start by giving you some information on my background and how I came to use modeling in my research. My interests and early training focused on how individuals make decisions about their health and the interpersonal, societal, and structural factors that constrain the choices available to people. When I was getting my PhD, I wanted to have a method that I could use to really translate what I was learning into actual public health impact. And I was drawn to mathematical modeling as a tool to understand these multi-level factors and how they together shape health outcomes. And I was also in particular drawn to the ability of models to inform policy and practice by systematically weighing the costs and the benefits of alternative strategies and scenarios. So I'll just point out, I don't have a very strong math background. I mean, I've trained in statistics and the math that goes into mathematical modeling, but my role as a mathematical modeler is as the epidemiologist on interdisciplinary teams. So I analyze data, I collect data to inform model inputs, think carefully working with stakeholders about what our model needs to represent in order to answer the questions that are most interesting and address the priorities of the groups we're trying to improve the health of. And I work closely with mathematicians and programmers to design models to effectively answer those questions. So my current work uses a combination of empirical epidemiologic research and mathematical modeling with a focus on improving prevention of cervical cancer. Before I get into the details on the project that I'm going to share with you today, I just wanted to provide some background on cervical cancer. So cervical cancer is caused by human papillomavirus, or HPV, which is sexually transmitted and is exceptionally common. Most men and women who are sexually active will be infected with HPV at some point in their lives. However, most people will clear their infection on their own. So about 90% of infections clear or heal within about 1 to 2 years. But for individuals with cervical anatomy, the virus may start to cause changes to the cells of the cervix that we refer to as precancerous lesions. For most people, these lesions will also go away on their own, but for some people, they will continue to grow and spread as cancer if they're not treated. Fortunately, there are highly effective interventions to prevent and treat this from happening at multiple points along this chain of events. We have highly effective vaccination to prevent HPV infection. There are strategies to screen and treat precancer and remove those precancerous lesions to prevent cancer from developing. And there are also treatments for cancer once it has progressed to that stage to prevent cancer from spreading. And given the availability of these effective strategies, in 2018, the World Health Organization set a goal to eliminate cervical cancer as a public health problem. And they defined elimination as getting to the point where less than 4 women per 100,000 get cervical cancer in a year. In the United States, routine screening to detect and treat precancer has been very effective in reducing the incidence of disease. And the guidelines for how often people should be screened and at what ages, what tests and treatments should be used have been informed by modeling studies. So I just put here an example of a paper that was instrumental for determining the latest guidelines for cervical cancer screening, and it was based on a modeling study. However, the progress in controlling cancer that we've seen in the US and in other high-income countries has not been achieved everywhere. Worldwide, there were nearly 570,000 cases of cervical cancer in 2018, but the vast majority of cases and deaths are in low and middle income countries. And the 15 countries with the highest cervical cancer incidence rate are all in sub-Saharan Africa. This figure shows the incidence rates in a selection of countries to highlight these disparities. So there are a number of reasons that we see these disparities, including differences in the availability of prevention programs. So HPV vaccination and screening and treatment have been widely available in high-income countries, but have not been as widely available in low and middle-income countries due to challenges with logistics and limited healthcare infrastructure. Another important factor that I want to highlight, though, is the biological interaction between HPV and HIV infection. Compared to women without HIV, women living with HIV are more likely to become infected with HPV, and their infections are more likely to progress to cancer. Among women living with HIV who are diagnosed and treated with precancer, data show that the treatment is not as effective. And together, these factors contribute to women living with HIV having a 6-fold higher risk of developing cervical cancer compared to women living without HIV. This figure I thought was interesting from a recent paper. They looked at data on cervical cancer and they tried to estimate the proportion of cervical cancer cases that are attributable to HIV worldwide. So this figure shows, in other words, that's showing the proportion of cervical cancer cases that could be prevented if no one had HIV. So if there wasn't HIV, there would be this % fewer cervical cancer cases. And in sub-Saharan Africa, this figure is more than half. So this interaction between HIV and HPV infection makes this an especially interesting area for mathematical modeling, which can be used to evaluate the combination of prevention strategies that will be most effective to reduce the burden of cervical cancer in settings with a high prevalence of HIV. To help answer these questions, my research group developed a mathematical model that simulates transmission and disease progression of both HIV and HPV. The model is calibrated or fit to represent the population of KwaZulu-Natal, South Africa, which is shown in the blue circled region on these maps, which is among the regions with the highest dual burden of HIV prevalence and cervical cancer in the world. So our model is a compartmental model, and it simulates HIV and HPV transmission and disease progression, accounting for the interaction between these two infections. So I don't get too into the weeds of the details of this diagram, but I just wanted to show how people in the model move between health states for both HPV in the top part of the diagram and for HIV in the bottom. And there are asterisks on some of these transitions on the top diagram to show that the risk of acquiring HPV and of HPV progressing through precancerous states into cancer depends on an individual's HIV infection status. So there's this interaction between the states in the model. Our model represents the use and impact of interventions to prevent and treat both HIV and cervical cancer. And these are the levers that we modify in our analyses. So we can change who uses these interventions and how effective they are to try to understand what combination of strategies will work best to prevent disease. Today, I'll show you some results from an analysis that estimated cervical cancer incidence over time in South Africa, using different strategies for HPV vaccination, screening, and treatment. To overcome health systems barriers that have limited the success of programs to date, we focused on strategies that are low cost and that make it easier for people to get treated. We defined 10 scenarios for this analysis that differ in the strategy that's used for cervical cancer screening, the proportion of individuals who come back for treatment after having been diagnosed with precancer, and the proportion of people who receive HPV vaccination. So this is a busy slide. I just want to walk you through a few things here. Our baseline scenario reflects current practice in South Africa, using a strategy that requires individuals to come back for multiple visits to receive treatment for precancer. And this has been a major limiting factor to current programs, is the current strategy requires people get screened and then their kind of samples from the screening are sent to a lab. Then they have to come back for another test to see if they do in fact have precancer, and then come back a third time to get treatment. And there's a lot of loss to follow-up. So many people don't receive treatment that is indicated and that could help prevent disease. So our interest with this paper was to look at new technologies that allow for single visit screening and treatment. So people can get results immediately from their screening test or within a couple hours, and then get treated in that same visit. And our is that will reduce the loss to follow-up. So it will result in more people getting treatment for precancer to prevent cancer. These strategies are also lower cost and more feasible to use in low resource settings. So we looked at scenarios assuming that this would allow people to get screened more often in accordance with guidelines. And in particular, we were interested in the impact of screening women living with HIV more often to address their increased risks for cervical cancer. This slide shows the results from our analyses estimating the age standardized cervical cancer incidence over time in the coming century. So the age standardized cervical cancer incidence is on the y-axis, and the x-axis is projecting into time until the year 2120. And just for reference, I've put these dotted and dashed lines to represent the elimination threshold of 4 cases per 100,000 and a nearer term target of 10 per 100,000. So this is what our model estimated in the baseline scenario. So if we continued current practices, we estimated that cervical cancer incidence would decrease 87% to an estimated rate of about 11 per 100,000 in 2120. So you may be surprised that there was such a big decline, given that I said the current strategies haven't worked very well. And there are 2 reasons for this decline. One is the effects of HPV vaccination, which is very effective, but it takes many decades to show an effect. People get vaccinated when they're sort of in the ages of 10 to 14, but cervical cancer doesn't really show up until the age 40 to 50. So there's a long lag time. But in the coming decades, we expect to see the effects of this vaccination program. Another important factor is current programs to treat women living with HIV using antiretroviral therapy are expected to decrease HIV prevalence and as a result, reduce cervical cancer incidence. But with improvements in HPV vaccination and screening, we can do better and try to bring incidence below this elimination threshold and make it happen sooner. So this green or teal line shows our estimated projections for cervical cancer incidence if vaccination was expanded to cover more people. We also looked at adding our switching to these single visit strategies to reduce loss to follow-up to treatment. And if we assume repeat screening, particularly for women living with HIV for these strategies, we see both near-term gains as well as long-term gains relative to the status quo. So in addition to looking at kind of the gains in preventing cancer, prevention strategies need to balance these gains in effectiveness with potential costs. Treatment of precancer is an invasive procedure and it's costly. And many women who show signs of HPV infection or precancer would heal on their own anyways. So we don't want a strategy that results in just everyone getting screened and treated all the time because there are downsides to that. So in this plot, we compare the strategies we modeled in terms of the percent of total cancer cases expected under the baseline scenario that are averted with each alternative scenario on the x-axis. So as we go further to the right, that means that more cancer cases are averted relative to the status quo. And we also looked at overtreatment. So on this y-axis, as we go higher, that means more cases are overtreated for each cervical cancer case averted. So we're looking for something that would get us in this lower right quadrant. And the individual points on this graph are the results from each of 25 simulations that we ran with each scenario to account for uncertainty in our model parameters. And the shaded regions just connect those points. So I'll just highlight that in our analyses, we found that a strategy combining HPV testing with use of a machine learning algorithm to identify cases that need treatment was the most efficient and effective in the South African setting. To conclude, the results from this modeling analysis indicate that elimination of cervical cancer as a public health problem is within reach, even in settings with a high burden of cervical cancer and HIV. To have success in these efforts, prevention programs will need to scale up strategies such as single visit screening and treatment to reduce loss to follow-up. And we'll also need to emphasize repeat screening, particularly for women living with HIV, to decrease disparities and advance progress towards elimination. So I'd just like to finish by thanking my collaborators and the funding sources that have supported my work. And I'm happy to take any questions. I think we'll have hopefully some time now, but I also included my email if anyone wants to reach out after this presentation. So thank you so much for your time.